Hi, this is Robin Blackstone. And today I'm introducing some podcasts that are going to air at the same day that they come out on LinkedIn newsletters as well as a Substack, because I know not everybody uses either of those tools. And so I want to make sure that these set of messages about Dr. AI, which is launching as a book on April 7th across all the platforms that you could want to listen to it on or read it on. There's a set of things that are real fundamental to understanding our healthcare system that people might want to know. So, Dr. AI, the podcast, is about that. Let me move forward to this article. This is on Substack. If you're on Substack, I'd love to have you comment on it. You can comment on my website, which is robinblackstone.com. Consent to Autonomy, the Human Principle, Dr. AI, and a New Architecture of Health. Health is not produced only in clinics. It is lived in culture, context, and time. Any system that does not center the person in that full ecology will continue to produce dependence and delay. I'm going to start with a summary narrative. Modern healthcare's deepest failure is not only fragmentation, cost, or lack of access. It is that the human being whose life is at stake is not the operating center of the system. Health is shaped in a lived ecology of culture, behavior, place, stress, family, meaning, social capital, and power. While healthcare usually enters only after that ecology has already expressed itself as a disease. Recent work in the progress in cardiovascular diseases is helpful here because it explicitly treats culture as a forcing factor for health outcomes, links successful health and well-being to social capital and healthy power dynamics, and uses regional culture as an analytical tool for understanding variation in health and its social and political determinants. That is why the human principle matters. It is not another name for patient, consumer, or user. It names the full person in context: a body, a history, a family system, a set of constraints, a culture, a pattern of behavior, and a life lived across time. Dr. AI follows that shift. Properly understood, it is not a synthetic physician or a friendlier search box. It is the continuous interpretive layer built in service of the human principle, the mechanism that carries context across time, surfaces meaningful changes earlier, and makes autonomy operational in daily life. The trust problem has to be named directly. A 2024 Nature Medicine study found that identical medical advice was judged less reliable and less empathetic, and people were less willing to follow it when they believed AI was involved. A 2024 digital medicine framework from Nature journals makes the stronger design claim: preserve trust between patients and clinicians while enabling justified reliance on the AI by both patients and professionals, with transparency, fairness, preserved shared decision-making, and involvement of patients and clinicians from the earliest stages. This data, carefully collected and well articulated in the articles, is also a bit out of date in terms of time frame. In 2022, ChatGPT launched its new engine. That moment was one of profound change. And in 2022 to 2024, there was a lot of back and forth about its capabilities, its hallucinations, and other manifestations of its inadequacy to meet human beings. However, over time, what has happened is it's learning to be much more, to be a really trusted companion. And I think that when you look at current data, the fact that 94% of clinicians are using AI daily, the fact that many patients are using chatbots across the spectrum of their lives during the day, I think you would find that trust in AI is growing. We'll wait and see what the papers have to tell us next. That makes Dr. AI, to continue with the article, a governance problem as much as a technical one. WHO's guidance, WHO, says AI for health must place ethics and human rights at the heart of design, deployment, and use, while NIST's AI risk management framework is explicitly aimed at promoting trustworthy and responsible development and use of AI systems. In other words, trust is not branding. It must be part of the operating architecture. Let's get into the full draft of the article now. The central failure of modern healthcare is not only that it is expensive, fragmented, and difficult to navigate. It is that the person whose life is at stake is not the operating center of the system. We built modern healthcare around institutions, around hospitals, benefit structures, reimbursement codes, professional silos, regulatory layers, clinical visits, and episodic interventions. The person appears within that system but does not organize it. Health is experienced personally, but it is managed externally. That is the design error. The consequences are larger than inconvenience. A system built this way can rescue, intervene, and treat. It can become extraordinarily sophisticated at moments of crisis. But it struggles to sustain health continuously because it does not live where health is actually made. Health is not produced only in a clinic. It is produced in the daily field of habit, sleep, work, stress, food, movement, relationships, meaning, neighborhood, schedule, fear, memory, and expectation. It is shaped by what a person can afford, what a person has learned to normalize, what a person can delay, what a person is ashamed to ask, and what a person believes is simply part of life. We have language for the clinical side of health. We have far less language for this lived side of health, even though it governs much of what eventually happens. I think of that lived field as personal health culture. A simple example makes the point. You brush your teeth every day. You eat, talk, work, smile, and move through life assuming that this part of your body will keep doing what it has always done. Then one day, a small crack, a neglected cavity, or a single bite on the wrong kernel of popcorn becomes pain. At first, it is brief and ignorable. Then it deepens. Then it takes over your attention completely. At that point, the healthcare system finally becomes real. But by then, what happens next is no longer determined by biology alone. It is shaped by schedule, coverage, transportation, fear, prior experience, pain tolerance, time off from work, childcare, and whether you are accustomed to minimizing what hurts. The system meets you only after your personal health culture has already been expressing itself for months or years. That is how much of healthcare still works. Not through continuous understanding, but through interpretation. This is why the current conversation about autonomy is often shallow. We tell people to take responsibility for their health, but we rarely give them the conditions that make responsibility possible. We will tell them to change behavior, but we do not equip them with continuous context. We tell them to comply with plans built in episodes, and then we describe their failure as a lack of discipline. What we call participation is something much weaker than ownership. It is consent. Consent matters, but consent is not autonomy. Consent is what remains when the important terms of action have already been set elsewhere. It is agreement without real command of context. It is participation without authorship. Autonomy is something stronger. It is the ability to understand and direct one's health in time, in context, and in relationship to what matters. That kind of autonomy cannot emerge from a system that encounters a person intermittently. If we are serious about having autonomy or restoring autonomy, then we cannot simply improve the interfaces of the existing system. We have to change its center. That center should be the human principle. The human principle is not the patient as the current system imagines them, not a diagnosis, not a chart, not a member, not a covered life, not a risk score, and not a utilization profile. The human principle is the full human being in context. A biology, yes, but also a history, a pattern of behavior, and also a family structure, a set of risks, and also a set of meanings. A body moving through environments, incentives, limits, and relationships over time. A person whose life is not episodic, even if the care still is. Once that becomes clear, the real function of Dr. AI becomes clear to also. Dr. AI is not a chatbot. It is not a digital front door. It is not a synthetic doctor with better manners. It is not meaningful because it can produce fluent answers on command. Dr. AI is the continuous interpretive layer built in service of the human principle in the Health 4.0 architecture. Its work is to carry context forward across time, to connect signals that would otherwise remain isolated, to identify meaningful change earlier, to translate complexity into terms that a person can actually use in the language they understand, and to support action before crisis becomes the first moment the system finally pays attention. It is the heart and soul of what we call trajectory engineering. In other words, Dr. AI matters less because it can answer questions and more because it sustains continuity. That continuity is what the current system cannot provide at scale. No physician, no matter how gifted or committed, can continuously inhabit the daily flow of a person's sleep, stress, trade-offs, exposures, choices, symptoms, and small biological changes. Clinical medicine remains indispensable, but it is episodic by design and by necessity. Human life? That gap between episodic medicine and continuous life is one of the places where avoidable illness is born. Dr. AI is designed to inhabit that gap. Not to replace the physician, not to impersonate care, not to manufacture intimacy, but to retain context, organize signals, support judgment, and help the individual stay in relationship with their own health between formal encounters with the system. This is where trust enters and where the argument has to become more precise. The word trust is often used lazily in discussions of AI. It is treated as a kind of emotional approval rating. Do people feel comfortable with the technology or not? That is too thin. The more rigorous distinction between trust and reliance is actually what is essential to understand. A person can trust a clinician because trust belongs to a moral and fiduciary relationship between human beings. An AI system is different. What matters there is justified reliance, whether the patient and the clinician can understand what the system does, what it does not do, what information it uses, how its inputs are documented, where its uncertainties lie, and when human judgment should take over. That distinction is at the center of one recent Nature publications journals in digital medicine framework, which argues for preserving trust between patients and professionals while enabling reliance on AI by both. This matters because the public does not automatically grant legitimacy to AI in healthcare. In the Nature Medicine study, people judged identical medical advice as less reliable and less sympathetic, and were less willing to follow it when they believed AI had been involved. It's important to note that that journal article reflected the very earliest days of ChatGPT's AI engine. That is a warning, though, against magical thinking. Performance alone will not carry this transition, despite the lack of hallucinations and improvement overall in all of the Chat GPT engines and Claude engines and other engines by Anthropic and others. So Dr. AI cannot be built as a black box wrapped in marketing language about empowerment. It has to be legible, it has to be governable, and it has to be bounded. It has to be designed so that a human being understands what is being inferred, what evidence is being used, what alternatives exist, and when escalation is required. That is why I think of Dr. AI not as a feature, but as trust architecture. Its first obligation is fidelity to the human principle. Its second is transparency. Its third is humility. It must know what it can do, what it cannot do, and when it should yield to physician judgment, team-based care, or emergency innovation and intervention. Anything less simply recreates the old design error with a more modern surface. It also clarifies the role of the physician. Nothing about this model diminishes medical expertise. It does the opposite. It protects it from being wasted on the impossible demand that physicians serve as the sole container of continuity for millions of lives unfolding in real time. The physician remains essential, but their role is realigned to current technical reality. Instead of being forced to carry every small question, every latent pattern, every contextual memory, and every routine translation burden, the physician can operate at the level where expertise is most needed: diagnosis, judgment, escalation, intervention, complexity, and care that truly requires a clinician. That is not displacement. It is realignment. And it only works if the human principle remains the governing center. Otherwise, Dr. AI becomes just another institutional layer optimized for throughput, cost, control of data, or workflow convenience. The risk is not merely that AI will fail. The greater risk is that it will succeed inside the wrong architecture. We already have enough tools to make the current system faster, denser, and more extractive. We do not yet have moral clarity about what those tools should be serving and who. That is why the literature on culture matters so much here. Recent work in progress in cardiovascular diseases is useful not because it provides a turnkey solution, but because it names something that healthcare often refuses to name. Culture is not peripheral to health behavior. It acts as a forcing factor, and health and well-being are shaped within ecologies of social capital, power, and place. That is very close to what I mean by personal health culture. A system that waits until disease appears has already missed much of the real action, and it has missed the influence that culture will have on the choices that the human principle can take about disease. In other words, it influences not only upstream pulse of health, but the downstream rescue and the choices made within that framework. A system organized around the human principle would look earlier, listen longer, and interpret more continuously. It would not ask individuals to become miniature physicians. It would give them a practical, ongoing relationship to their own health. It would not confuse data possession with understanding. It would help people see what matters, why it matters, and what kind of response is proportionate. That is the beginning of autonomy. Not the lonely burden of choosing better in the dark, but the real ability to understand one's own health in context and act with support. Responsibility becomes possible only when understanding becomes continuous. This is also why governance cannot be an afterthought. WHO's guidance on AI for health places ethics and human rights at the center of design, deployment, and use. And NIST's AI risk management framework is explicitly aimed at trustworthy and responsible development and use. In a field as intimate and consequential as health, those are not compliance boxes to be checked. They are part of legitimacy itself. The old system was built around institutions and episodes. The emerging system will be built around persons and continuity. That is the shift. The human principle is the rightful center of health. Dr. AI is the interpretive and trust architecture that makes that centering operational within the Health 4.0 framework. If we get that wrong, we will automate fragmentation. But if we get it right, we will do more than improve healthcare within a single system. We will have created a model that health systems around the world can adapt, one that creates value in human health continuously over the course of a life. That is the real work. Working Source Stack. The first paper is by Frederick J. Zimmerman and Nicholas P. Pronk, Socioeconomic Milieu and Culture, Forcing Factors and the Most Fundamental Determinants of Health. Progress in Cardiovascular Diseases, 90. Publication 2025. Number 2, Colin Woodard, Ross Arena, and Nicholas P. Pronk, The American Nations Model, an analytical tool for understanding the influence of U.S. health regional cultures on health and social and political determinants of health. Progress in Cardiovascular Diseases, 90. Publication 2025. Nicholas P. Pronk, Colin Woodard, Frederick Zimmerman, and Ross Arena, An Ecological Framework for Population Health and Well-Being. Progress in Cardiovascular Diseases, 90. Published in 2025. Mortiz Rice, Florian Rice, and Wilfred Kunde, Influence of Believed AI Involvement on the Perception of Digital Medical Advice. Nature Medicine, 30, 2024. Lena Christine Zukowski, Matthias Lucas Zukowski, and Eckhard Nagel, A Trust-Based Framework for the Development of Medical AI. Partner AI Journals, Nature Partner Journals, NPJ Digital Medicine, 7, 2024. World Health Organization, Ethics and Governance of Artificial Intelligence for Health, 2021. National Institute of Standards and Technology, Artificial Intelligence Risk Management Framework, AI RMF 1.0, 2023. This is Robin Blackstone, publishing on Substack and podcasts on Podbean and other platforms like Spotify and Apple. My website is robinblackstone.com. The book, Dr. AI, Reimagining Health, Rebuilding Trust, Delivering Health 4.0, will be published on Amazon April 7th, 2026. It can be ordered in all audio and written formats, including ebook, hardcover, and paperback. I hope you'll join me in the exploration of Health 4.0, the next operating platform for health globally. Thank you.